Good afternoon, ladies and gentlemen. Let me first introduce myself. I'm Alex Voivod. I'm a consultant physician and nephrologist at Lancashire Teaching Hospitals NHS Foundation Trust in Preston in the northwest of England. My interest in renal transplant ultrasound stems from 8 years or so of performing renal transplant ultrasound myself. From my training in Germany, I'm also formally certified according to step 1 of the guidelines of the German Society for Ultrasound in Medicine. I also perform regular courses on renal and renal transplant ultrasound for junior and middle grade nephrologists. Now, the menu of today's talk, as it were, is given in this slide. We will first discuss what transplant ultrasound can do and what its role is in clinic, and more importantly, we'll also discuss what transplant ultrasound cannot do. We'll then move on to common findings in B-mode ultrasound, and then progress to the more advanced Duplex and Doppler ultrasound of the renal transplant. We'll go over common findings and start with the not so difficult things such as measuring the renal resistive index, and then move on to the more advanced evaluation of transplant renal artery stenosis. And finally, I'll try to formulate a standard, as it were, of what a proper renal transplant ultrasound should cover. Now, when I perform renal transplant ultrasound, I sometimes feel like the man on this beautiful painting by Hieronymus Bosch, The Imposter. Now, the imposter, that's me in this allegory. I perform the renal transplant ultrasound, the others are watching. Some of them can't quite believe what's going on, some of them come closer to try and understand what's going on. Others look away entirely, some look up to the sky and just don't believe what's going on. What can transplant ultrasound do? What it can do, very importantly, is exclude obstruction, and that's actually probably the most important thing that renal transplant ultrasound is good for. We can exclude obstruction in a transplant that is deteriorating, and that's actually quite easy. Every renal registrar and every junior renal doctor can do that with a little bit of training and a bit of supervision and experience. We can also provide evidence for or against an acute problem, in that we can measure the renal resistive index. Again, that is not as easy as excluding obstruction, but it's not really difficult and can be done with a bit of experience and supervision. We can also prove patency of the transplant artery and vein post-operatively. That is actually very important in an acute transplant unit. So if you work in an acute transplant unit, then you will know how important it is to know that the transplant artery and vein are patent if, for example, a transplant deteriorates in the first 24 hours after surgery. What we can also do is diagnose or exclude transplant renal artery stenosis, although I think it's fair to call that advanced, and that needs a fair bit of experience and supervision, and that is for the advanced ultrasound wizard. What it cannot do is equally important. Transplant ultrasound can't diagnose or exclude rejection. The best we can do is provide evidence of an acute problem by measuring an increased renal resistive index, but to diagnose or exclude rejection is actually still the role of the transplant biopsy. Now, what do we expect to see? It's worthwhile to spend a slide and a couple of minutes on the anatomy of the renal transplant. Most transplants are fitted into the right iliac fossa. The vessels connected usually to the iliac vessels. In this case, the common iliac artery and the common iliac vein can also be connected to the external iliac artery or vein. And then we have the transplant ureter that is connected to the recipient's bladder, as shown in this cartoon. It's worthwhile to know if the patient has had his transplant or her transplant in childhood. In that case, we can expect the transplant artery to be connected directly to aorta, and the transplant vein probably connected to the inferior vena cava. Kidney pancreas transplants, slightly different in their anatomy, in that the kidney graft is usually in the left iliac fossa, and it's not retroperitoneal as in the isolated kidney transplants, but intraperitoneally. However, we can't visualize that on ultrasound, as the peritoneal folds are usually not visible on ultrasound. The pancreas transplant usually on the other side, in the right iliac fossa, although pancreas transplant ultrasound is largely unknown territory and will not be covered in this talk. It's a nice challenge for the advanced ultrasound practitioner, but we have yet to learn the meaning of, for example, the resistive indices in the pancreas transplant, or measuring the volume of the pancreas transplant. That is unknown territory. Its meaning is not yet known. How to get started? Well, in a fresh and well-functioning transplant, that should be a piece of cake. To find the correct side, usually there will be a well-delineated scar, and we will just place the transducer in parallel to the scar. It is important, as a bit of ultrasound etiquette, to be gentle. Many patients have hyperesthesia in their iliac fossa that contains the transplant. This is because nerve damage has occurred during surgery, and quite a few patients are very sensitive there, so be gentle and the patient will be your friend. There should be no problem in finding a functioning transplant, and by this stage you should have found the transplant alright. In a non-functioning transplant, a patient who has already returned back to dialysis, that may be quite a bit more difficult to find, and the following rules may help. All that pulsates, all that has peristalsis, and all that changes shape with flexion of the leg is probably not the allograft. So that will allow you to differentiate between the transplant, the old non-functioning transplant, and, for example, bowel or muscle. Using these rules, it's usually possible to find even an older non-functioning transplant, although after years of returning to dialysis, that may be a challenge and something for the more experienced ultrasound wizard. Size, length and volume of the transplant. I'll spend quite a few minutes and several slides with this, as many mistakes are made there in clinical practice. We first have to appreciate that there is a difference between renal length and renal volume. Most ultrasound reports of transplants provide the renal length, although actually what correlates with the patient's body weight is the renal volume. The kidney is an ellipsoid body, so there is a mathematical formula to approximate the volume of an ellipsoid body, such as a native kidney or a kidney transplant, and this is the formula. It will be length times breadth times depth times p divided by 6. The mathematical number p divided by 6 usually equates to roughly 0.5, so a times b times c times 0.5 is a good estimation of the renal volume. And the normal renal volume in a native kidney relates to body weight, in that the normal renal volume should be body weight of the patient times 2 plus minus 20%. However, here lurks the major problem, because in native kidneys, obviously, the kidney volume relates to the patient's body weight, and in transplants, the transplant volume will obviously relate to the donor. So, if a 6 foot tall muscular man receives a tiny transplant from a adolescent tiny girl, then the volume of that transplant will not relate to the 6 foot muscular man, but to the body weight of the tiny adolescent donor. So, in a nutshell, there is no normal size in transplant, as the volume relates to the donor. So the correct wording in a transplant renal ultrasound report would be: the renal volume is appropriate or not in relation to recipient, not the renal transplant has a normal size. So what we can do is we can measure the renal transplant volume, relate that to the recipient's body weight, and then call the renal transplant volume appropriate or not in relation to the recipient. How to measure the renal volume? First, obviously, we need to measure the length of the transplant. That needs a bit of patience. We need to obtain several readings until we are convinced we've actually found the longest length of the transplant. To measure B and C, we need to apply the 90 degrees trick. How is that done? That is done by placing the transducer on the longest length of the transplant, as shown on the left hand side, and then rotating the transducer by 90 degrees. This is what beginners usually find extremely difficult. The best way to do it is usually to look at the transducer and your hand that holds the transducer, and not look at the screen. And actually, in my ultrasound courses, I will usually cover the screen with a cloth to make it easier for the beginner. So what you do is identify the longest length of the transplant, have your transducer alongside the longest length of the transplant, rotate the transducer by 90 degrees, and then you will usually see this picture, 90 degrees to the longest length, so a nice transverse cut of the transplant, and you've already found the hilus. By convention we measure B and C at the level of the hilus where the vessels come in, and even without applying Doppler and Duplex you can see that this is the transplant artery and vein coming in, and this is just spot on. So then you've obtained A, B and C, and you can calculate the renal transplant volume and relate that to the recipient's body weight and call it appropriate or not. Parenchymal width can be measured at the same spot where you've just measured A and B as detailed before. Obviously there are several measurements that can be obtained, and indeed a good transplant ultrasound report should then provide several readings. So for example in this case you would say that the parenchymal width is between 10 and 13 millimeters. It would be abnormal if that was below 10 millimeters. That's worthwhile to keep in mind. Now moving on to parenchymal changes. For that, unfortunately, we don't have the luxury of normal values. We can only rely on experience obtained with measuring and seeing hundreds or thousands of transplants. This is how a normal transplant parenchyma should look like, and please note that there's a clear-cut border between the transplant parenchyma and the surrounding tissues, and please also note that the transplant parenchyma is smooth and has a straight lining and is well demarcated against the surrounding tissue. Now if we compare that to another transplant, I think it's very obvious that there are parenchymal changes compared to the previous picture. To start with, there is no clear-cut delineation between the transplant parenchyma and the surrounding tissue. That has been lost already as a sign of parenchymal changes, and also the parenchyma itself is inhomogeneous with echo-dense and echo-poor areas, and that is what we would classify as at least moderate parenchymal changes. Moving on to the next picture, a transplant that may even be difficult to find in a patient who has already returned to dialysis, no clear-cut border to the surrounding tissue at all, and very inhomogeneous parenchyma. So this is what we would call severe parenchymal changes. Another important finding in the parenchyma, prominent medullary pyramids, as seen in this transplant. Medullary pyramids very obvious in this picture as echo-poor areas, and if you compare that to the pathology findings of such a kidney, then it's very obvious that these are indeed the medullary pyramids, as in this transplant kidney from a patient with acute transplant failure. This is unfortunately what we call a soft sign. It can be seen even in some healthy transplants. It occurs in acute transplant failure regardless of the cause. It can also occur in acute rejection. So prominent medullary pyramids, a soft sign of acute transplant failure, but important to remember that it can also be seen in healthy transplants. Moving on to obstruction and its many variants. I've said that excluding obstruction is one of the most important things of transplant ultrasound. We will start with something that is not obstruction, as seen in this picture. So what we can see in this picture is merely a dilated transplant pelvis. The transplant, here the transplant pelvis, and note that the calluses are not dilated at all. It is merely the pelvis that is dilated. This is ectatic pelvis of the transplant, or also called pilectasia, and not relevant obstruction. So this would not in itself warrant further tests or referral to a urologist. This is merely a variant of the normal as long as the calluses are not dilated. Also worthwhile to remember that we are not permitted to diagnose obstruction with a full bladder. So if this was seen with a full bladder, then the next reasonable step would be to send the patient to the toilet and repeat the transplant ultrasound. Very often these signs would then disappear. So do not diagnose anything that is connected to obstruction as long as the bladder is full. Another variant of the norm, in this case, segmental dilatation of the calluses. Here the transplant in the left iliac fossa, and what we can see is dilated calluses but not proper obstruction. If we would have a look at another section of the transplant, there would be no visible calluses at all, so this is just segmental dilatation of the calluses, again a variant of the norm and does not necessarily warrant further investigations. This is often seen in patients who have experienced recurrent urinary tract infections and scarring, and does not necessarily imply any abnormal pathology. Now moving on to proper obstruction, and again people's preferences as to the grading of obstruction differs between countries and continents. There's a grading for obstruction obtained from first from children's native kidneys and also used in adult nephrology and urology. Some people would just say mild, moderate and severe obstruction, which I prefer because I think the grading sort of gives the illusion of a more precise classification than we actually have. Now in this picture you can see a severely dilated pelvis of the transplant extending into the calluses, and this is proper obstruction, at least moderate I would say, and we can also see the ureter of this transplant dilated, and in this case it was a stenosis of the transplant ureter close to where the transplant ureter enters the urinary bladder. If you are not sure how bad the obstruction actually is, the best thing is to have a look at the transverse view, where it usually becomes very clear. The pylon, the renal pelvis dilated and extending into the calluses. This is particularly helpful if you don't know whether the calluses are dilated. Then the best thing is obtain a transverse view, and that will often make things very clear. Another variant of the norm, not necessarily abnormal, not necessarily should this prompt further investigations, is the visible transplant ureter, as in this case a transplant in the right iliac fossa, transplant with parenchymal changes, and here you have the visible transplant ureter but nothing else. The renal pelvis not dilated, the calluses not dilated. Again, that's not proper obstruction, that is a visible transplant ureter, and that has uncertain significance. It needs to be mentioned in the report, but it should not in itself trigger further investigations. This is something that we sometimes see in the early post-transplant period. This is a dilated pelvis of the transplant with the pigtail catheter in situ. The pigtail is what the transplant surgeons tend to put inside to allow healing of the ureteric anastomosis, and the pigtail catheter is usually seen as a double contour within the transplant pelvis. Obviously the pigtail will be removed 6 or 8 weeks after transplantation, so if you see this a couple of months after transplantation, that will usually imply that someone forgot to take the pigtail catheter out. We spent the last couple of slides on obstruction and on variants of the norm regarding the transplant ureter and the transplant pelvis. This is another finding that is commonly seen in transplants. A renal transplant in the transverse view, the renal transplant pelvis, but within the renal transplant pelvis we see a thickened urothelium of 2.4 millimeters. This is often seen in recurrent or chronic urinary tract infection of the transplant. However, we need to appreciate that this too is a soft sign, meaning that there is no clearly defined upper limit of normal for the thickness of the transplant urothelium. Another common finding in transplant ultrasound, the lymphocele, here in a picture from Christoph Thalhammer's review article, the transplant in a longitudinal view, next to the transplant a large cystic structure, echo-free. This is a typical lymphocele. How does a lymphocele occur? The lymphocele is caused by transection of lymphatic vessels by the surgeon at the time of the transplant surgery. This will then lead to accumulation of lymphatic fluid in direct vicinity to the transplant. If we switch on the color duplex, then the lymphocele may look even more frightening. We can see the transplant artery and the transplant vein traversing the lymphocele. This looks frightening and may cause unnecessary fear, and some juniors will then try to mobilize the vascular surgeon or a transplant surgeon to intervene. However, these junior doctors can usually be reassured. It looks frightening, but catastrophic bleed into the lymphocele is unheard of. So although the transplant artery is in direct vicinity to the lymphocele or transverses the lymphocele, bleeding is almost unheard of. Another classical lymphocele, the transplant in a longitudinal view next to it, a cystic structure, no interior echoes. That is another small lymphocele, and again that would not need any intervention. The only reason for intervention in a lymphocele would be if it's so large that it will compress the transplant ureter and cause obstruction. In that case, surgical intervention is usually necessary. Moving on to another common finding in transplant ultrasound, the cysts. Here I've brought you a 12 mm simple cyst within a renal transplant, a clearly defined hairline wall and no interior echoes, a simple cyst. It's worthwhile to spend a couple of minutes on the classification of renal cysts. I reckon that most of you will be familiar with the Bosniak classification of renal cysts that I've brought here. It's worthwhile to remember that the Bosniak classification at its extremes has the class 1 cyst, as I showed you just now, a benign simple cyst, hairline thin wall, no septa, no interior solid components. At the other extreme of the spectrum, the class 4 Bosniak lesion, a clearly malignant cystic mass with soft tissue components. These will need surgical exploration and a tissue diagnosis. The classifications in between, from 2 to F to 3, are somewhat more controversial, and it's probably fair to say that even seasoned ultrasound practitioners may find it difficult to differentiate between a class 2 and a 2F lesion. Part of the controversy stems from the fact that this classification is actually not an ultrasound-based classification. It is, in its very roots, a CT-based classification. So it's not validated for ultrasound, nor for that matter for transplant renal ultrasound. Many people therefore prefer to speak of simple cysts, clearly suspicious cysts, or mildly or moderately atypical renal cysts instead of using the Bosniak classification. If used in ultrasound reporting, one should probably say something like, this is a simple cyst 12 mm equivalent to Bosniak class 1, to emphasize the fact that the Bosniak classification is not directly applicable in ultrasound. I've brought an example of one suspicious cyst, a transplant in the longitudinal view in the right iliac fossa at the upper pole of the transplant, a cystic structure with hairline thin septa within, but in addition to that a solid structure within this cystic structure. On high resolution ultrasound with a linear transducer, that becomes even better visible. We can clearly appreciate the septa that we've seen before and the solid structure within the cystic component. Further evaluation of this abnormal cyst and clearly suspicious cyst will also comprise power Doppler ultrasound looking for increased vascular supply, and in this case I'm sure you will agree that this suggests increased vascular supply in the vicinity of the lesion, although reassuringly the solid components within do not have increased vascular supply. And again, increased vascular supply is of course a very suspicious sign in renal cysts. In this case, second imaging was requested in the form of an MR scan, where the lesion looks even more worrying with this solid component and an irregular wall. Unfortunately, this patient declined further surgery and further interventions. As far as I know, the patient is still well 2 or 3 years after this diagnosis was made, so we can be reassured that this was probably not a renal cell carcinoma. Obviously, the decision for surgical intervention is not an easy one, as it may lead to not only removal of the cyst, but potentially loss of the transplant. Moving on to color, duplex and Doppler ultrasound of the renal transplant. Let's first start with the renal resistive index. The renal resistive index was devised by a man called Porcello according to this formula, also known as the Porcello index. Not surprisingly, Porcello was double qualified as a medical doctor, as a radiologist, and also as an electrical engineer, and it's probably fair to say that he was one of the forefathers of today's Doppler ultrasound. If we go away from the formula and just look at these waveforms, then the easiest way to remember the resistive index is to say that the renal resistive index is a measure of the diastolic flow. That is, good and proper diastolic flow, as in this waveform, equals a normal renal resistive index. In a transplant, that would be between 0.6 and 0.8. Poor diastolic flow, as in this waveform, equals high resistive index. As I said before, the upper limit of normal is probably 0.8, and a renal resistive index of 0.86 is clearly elevated. What does that indicate? It merely indicates that the transplant is acutely unwell. It does not provide a tissue diagnosis. This can be caused by acute rejection, but also by acute urosepsis and urinary tract infection, or acute renal failure of the transplant of any other cause. In contrast, a renal resistive index between 0.6 and 0.8, broadly speaking, indicates that the transplant is well. So this is a good way to remember the renal resistive index. High renal resistive index indicates poor diastolic flow due to parenchymal swelling, due to the transplant having an acute problem. Proper diastolic flow results in a normal resistive index between 0.6 and 0.8. It's also important to remember that if the transplant renal resistive index is very low, as in below 0.6, this may indicate transplant renal artery stenosis, and we'll come back to that later. Another example of a very high renal resistive index, in this case resulting in a renal resistive index of 0.9, and how to calculate the renal resistive index, I will show you that in the next couple of slides. However, also worthwhile to remember that the renal resistive index is actually a marker of transplant and recipient outcome. This was nicely shown in the very large study by my ex-colleague Jörg Rademacher, published in the New England Journal of Medicine in 2003, showing that actually the renal resistive index is the strongest marker of outcome, meaning that the lower the renal resistive index, the better the outcome. High renal resistive indices indicate a poor outcome for the transplant and the recipient. Where to measure the renal resistive index? It's very important to become familiar with one's own ultrasound machine and the algorithm that the machine uses, but it's still very important to know where to measure. And that is shown in this picture. It's very important to measure the renal resistive index in the distal segmental artery. Why is that? That is because the renal resistive index changes along the course of the arterial vascular tree. Therefore, by convention, the renal resistive index is measured in the distal segmental artery. We don't want to measure in the main transplant renal artery. We don't want to measure within the parenchyma. No, we want to measure at the level of the distal segmental artery. Also important is to do repeat measurements. So a seasoned ultrasound practitioner will probably do 3 or 4 repeated renal resistive indices at the same site. Also important is to measure the renal resistive index at the upper pole of the transplant, the lower pole of the transplant, and the middle pole of the transplant. Why is that? Some patients may have several transplant renal arteries, for example a main transplant renal artery and an accessory upper or lower pole transplant renal artery. In this case, the only way to pick up an abnormally low renal resistive index indicating stenosis of one of these multiple arteries is if you actually measure the renal resistive index at the upper pole, the middle pole, and the lower pole. Moving on to measuring the pelvic vessels, here you can see the transplant, and below that in black and white the iliac artery. And if we use power Doppler, that becomes very clear, the iliac artery and the origin of the transplant artery. What do we want to measure in the iliac artery? We want to check the iliac artery behind the origin of the transplant artery. The easiest way to do it is to place the transducer alongside the iliac artery and measure very close to where the iliac artery, the external iliac artery, becomes femoral artery, because that would surely be very much behind the origin of the transplant artery. We expect to see a triphasic normal signal as shown in this picture. Very commonly we also see a biphasic signal in elderly recipients or if there is atherosclerosis. Monophasic signals are abnormal and also seen in atherosclerosis. A dampened arterial signal in the iliac artery A dampened and monophasic signal indicates stenosis of the iliac artery. This is what we refer to as the clamp stenosis. The clamp stenosis is caused by the surgical clamp that the transplant surgeon applies to the iliac artery when the transplant surgery is performed. This is a predilection site for stenosis of the iliac artery. Hemodynamically, the clamp stenosis behaves like a transplant renal artery and is equally important to pick up on transplant ultrasound. Therefore, it's imperative that we always check the iliac artery. Moving on from the iliac artery to the arterial anastomosis, it's important to spend a bit of time on variants of the arterial anastomosis. Now, this is obviously a very delicate structure in theatre. There are several variants. Most commonly, the transplant artery is anastomosed to iliac artery with an aortic patch, that is in cadaveric transplantation. Also possible, multiple arteries without a patch, or on the right hand side, multiple arteries with one patch originating on one patch. Now, for obvious reasons, live donor anastomosis is different. Most donors are very reluctant to give away part of their abdominal aorta, so the live donor anastomosis has no patch. If we look at that on ultrasound, the iliac artery seen here, duplex ultrasound shows the origin of the transplant artery. This is a very simple situation. One transplant renal artery probably with an aortic patch, but normally we can't see the aortic patch. So iliac artery, transplant artery originating in a 90-degree angle from the iliac artery, and there's only one of them, the simplest situation that we can possibly encounter. Along the cartoon that I've shown initially, another possible situation, two transplant renal arteries, again this the iliac artery, one transplant renal artery, second transplant renal artery, probably because they are so close, originating on the same patch, but the patch again cannot be seen on ultrasound. Very often the transplant renal artery can be visualized if the patient is slim, even without duplex ultrasound, as in this situation. This is a transverse view, the iliac artery, and originating from the iliac artery, the transplant artery visible even without color duplex. It is sometimes difficult to visualize the transplant artery, especially if the patient is a bit more obese. Something that can help a great deal is power Doppler, as shown in these cases. The power Doppler has the great advantage that it's more sensitive to flow than the conventional duplex, at the expense that it cannot show the direction of the flow. So power Doppler will only show one color, but is a lot more sensitive in picking up the flow. Very helpful in obese patients, as seen in these pictures, the iliac artery seen here, and clearly defined the transplant artery originating from the iliac artery, or on the other side, iliac artery, transplant artery originating here. So to remember, whenever it's difficult to find the course of the transplant artery, especially in obese patients, power Doppler may help. Transplant renal artery stenosis, a few words on that, although as I said before, that is advanced renal transplant ultrasound and needs a lot of experience. Transplant renal artery stenosis is an important cause of hypertension in transplant patients, and therefore it is worthwhile to check for transplant renal artery stenosis in almost every transplant patient. There are mainly two forms. One is early on due to swelling of the arterial anastomosis, or if there is a pre-existent stenosis that has been overlooked in cadaveric donation or overlooked on the MR scan in live donation. There is the second variant of late transplant renal artery stenosis, and that is largely due to atherosclerosis of the anastomosis. The transplant renal artery stenosis can occur early on in live donation transplants. That is basically because there is no aortic patch. Ultrasound diagnosis of transplant renal artery stenosis needs a lot of experience, as emphasized before. The criteria for diagnosing transplant renal artery stenosis remain somewhat controversial, as reviewed nicely again by Christoph Thalhammer from Switzerland in his review in 2007. most people would say that maximum velocities in a healthy transplant renal artery are up to 250 centimeters per second. A proper transplant renal artery stenosis, most people would agree, will need velocities around 400, 300, 400, 500 and above centimeter per second. This is an example of the transplant renal artery, and during the course of the transplant artery, an area of aliasing, or also known as the confetti phenomenon, if we interrogate with the Doppler probe, we can see markedly increased velocities, in this case up to 440 centimeters per second. That is a proper transplant renal artery stenosis. There are formulas that help us to gauge the severity of transplant renal artery stenosis. That unfortunately is slightly beyond the scope of this talk, but the formulas can give us an idea of the degree of transplant renal artery stenosis. The formulas will need measurement of the velocity within the stenosis as well as beyond the stenosis, so at the hilum of the renal transplant. If you have those two velocities, you can calculate by a formula the estimated severity of the stenosis. Another example, maximum velocity 426 centimeters per second. That is clearly abnormal within the transplant renal artery. Moving on to indirect signs, we've discussed the direct signs, that is to demonstrate increased velocity within the stenosis in the transplant renal artery stenosis. Indirect signs pertain to signs that can be obtained within the transplant beyond the stenosis, and this is the classical sign called the tent sign, meaning due to a severe and hemodynamically relevant stenosis, there will be delayed increase of the systolic velocity as seen here. So whereas a normal flow signal will lead to a sharp increase of the systolic velocity in transplant renal artery stenosis, there is a delay in the increase in velocity, and that is called a tent sign. And I think you can see that this signal broadly resembles a tent. We can also measure the acceleration time, that is the time from the beginning of the systole to the maximum systolic velocity. That is called the acceleration time, and that can be measured as well. I've mentioned before that we need to check the iliac artery to detect clamp stenosis. This is an example of a clamp stenosis. The transplant here, the iliac artery here, and here the aliasing in a iliac artery stenosis prior to the origin of the transplant artery. Again, hemodynamically that will behave like a transplant renal artery stenosis, and is just as important to pick up but more difficult. Another rare finding in duplex enterprises of the transplant is this, a thrombosed pseudoaneurysm of the transplant artery. So you can see the thrombosed pseudoaneurysm here without any flow on duplex measurement, and this the transplant renal artery. This was a sequel of surgical catastrophe with bleeding and a pseudoaneurysm of the transplant artery, which fortunately went well, and the aneurysm thrombosed by itself, and could be seen years later on ultrasound as this thrombosed pseudoaneurysm. Sometimes the transplant renal artery is anastomosed to aorta, or there are variants of the arterial anastomosis as shown in the first cartoon. In this example, this is a transverse view of the abdominal aorta, the distal abdominal aorta, and they're originating from the distal abdominal aorta, the transplant renal artery, with marked aliasing and the confetti phenomenon, and a markedly increased velocity in this transplant renal artery of 600 centimeters per second. So this was a moderate transplant renal artery stenosis in a transplant renal artery anastomosed to aorta. That was not a pediatric patient. This patient had received his transplant after a long history of retroperitoneal fibrosis, and the transplant surgeons felt that an arterial anastomosis to aorta was the only anastomosis that was technically feasible. Another thing that helps if the anatomy is not straightforward, as in this case, before embarking on hours of duplex ultrasound to try and find the exact course and possibly the number of transplant arteries, a good thing is to obtain the surgical notes first. These will usually detail how the arterial anastomosis is done, and equally important, how many transplant arteries there are. And then, after you've seen the surgical notes, return to the patient and try to identify the arteries and the anastomosis as detailed in the surgical notes. Also important is that an accessory transplant artery is easily overlooked. This can be potentially very important, as an accessory transplant artery may carry a stenosis just as the main transplant artery. Therefore, if in doubt, and if you really want to make sure you've seen all transplant arteries and you've really excluded transplant renal artery stenosis, have a look at the surgical notes and then go back to the patient if necessary. The overlooked transplant renal artery stenosis, transplant artery may have a stenosis as well, and that's why it pays to spend a bit of time with the surgical notes. Another finding in transplant ultrasound is this, an AV fistula that usually occurs after a transplant biopsy. What is it? It is essentially a shortcut between a transplant artery and vein, usually the segmental artery and vein. It is seen as a large area of aliasing within the parenchyma. These can be very large, up to several centimeters, and become hemodynamically significant. Proof of the fact that this is an AV fistula requires measurement of the renal resistive index in the distal segmental artery that feeds the AV fistula, and this would probably be the artery that feeds the AV fistula in this case. In that artery that feeds the AV fistula, the resistive index will be low, or indeed very low, because it is essentially a shortcut with a very high diastolic flow. These arteries that feed an AV fistula may have renal resistive indices as low as 0.5, 0.4. A very rare finding, but important in the early post-transplant period, transplant vein thrombosis with a pendular flow in the transplant. This is a transplant surgical emergency that requires immediate intervention. Pendule flow in the arterial system, so this is the arterial system within the transplant. Pendule flow signaling acute venous thrombosis of the transplant, a surgical emergency. Now, in the last slide, I would like to propose what a proper transplant renal ultrasound should comprise. As detailed in the first part of the talk, measure the size and the volume of the transplant, relate the volume of the transplant to the body weight of the recipient, and say whether the volume of the transplant is appropriate or not in relation to the body weight of the recipient. Measure the width of the parenchyma and comment on parenchymal changes. Exclude obstruction, have a look at the bladder. We've not covered that in this talk, but it's also important in transplant ultrasound to have a look at the urinary bladder to see whether there is, for example, prostate enlargement. Have a look at the transplant ureter and comment on these findings. Check the surroundings of the renal transplant for lymphocele and for fluid in hematoma, again something we've not covered in this talk. Measure the renal resistive index in the upper, middle and lower pole of the transplant. Each time repeated measurements are necessary, for example 3 repeated measurements each at the upper, middle and lower pole. Check the signal of the iliac artery and beware of the clamped stenosis. Identify the origin of the transplant artery and try to exclude stenosis of the transplant artery. And finally, check the entire transplant with duplex and look for a post-biopsy AV fistula. This is quite nice to know, especially if you plan another biopsy. Then you will know whether the AV fistula has been pre-existent or has indeed been caused by your biopsy. So this was the end of the talk. I hope this was interesting for the audience. I have no conflict of interest to disclose. I have some acknowledgments to make. First and foremost to Professor Gebel in Hanover, my ultrasound teacher. I'm very indebted to this man for teaching me the basics of abdominal ultrasound, and also to his colleague Dr. Black, who's now in Stendal in Germany. I learned a lot about renal and transplant ultrasound from Dr. Marcus Hiss, consultant nephrologist at Hanover Medical School. I'm also indebted to my colleagues and co-organizers of the Preston Renal Ultrasound course, Dr. Schultz and Dr. Ferring from Worcester, and I'm also indebted and owe thanks to Toshiba Medical Systems both in Germany and the UK, for many years of excellent technical support. Thank you very much for